Yeah. So, good evening and good afternoon to all those viewers who joined us for this first year's IPL series. We call as Interact with the Pioneer and Learn. And for that, we are really fortunate enough to have Dr. Tim Hems or Timothy Hems. He's one of the finest brachial plexus surgeon from the Department of Orthopaedics, Queen Elizabeth Hospital from Glasgow. He has done an incredible work on brachial plexus injuries, and we are also happy to have him as the first pioneer to talk on brachial plexus injuries, especially for the Journal of Hand Microsurgery, which has the idea of conducting one IPL series in every month. We call it 2020 because the speaker will speak for 20 minutes and then we'll have a good discussion on the topic for 20 minutes. Beyond that, I think we really focus on having one particular topic specific to the current needs of all these viewers. The viewers are mainly from all parts of the country, all parts of the world. They view this program through Facebook, YouTube, and other social media, just the idea to disseminate the knowledge. Along with us, we have one of the finest brachial plexus surgeon. I think one of the incredible surgeon in India. I think I can name a few. One among them is Brigadier Dr. P.S. Bhandari. Thank you so much for joining us today as a moderator, and really we're happy and privileged to have both pioneers here. In fact, it's a day we really need to have a choice of having both pioneers who are talking on the brachial plexus injuries, which of course their own dream or their own area of interest. So this short introduction, I invite and take pleasure to invite Dr. Tim Hems to talk on the infraclavicular injuries in the shoulder and trauma, the pattern and implications. Thank you so much once again, Dr. Tim, for joining us. Please go ahead, and I'm going to make you as a presenter again. You can share the screen there.
Thank you very much for the introduction and inviting me. So if we go to here, should be all right. Okay.
Perfect.
So thank you very much for inviting me to join in this webinar. I, as Terrence says, work at the Queen Elizabeth University Hospital in Glasgow. To give some background, my part of my work, but not all my work, is for the Scottish National Brachial Plexus Injury Service. This is based in Glasgow. We started the service in 1997, and it became a designated national service for Scotland in 2004. So we're the only brachial plexus centre in Scotland. We serve a population of about 5.5 million people. We provide a service for diagnosis, surgical management, both primary and secondary repairs, and rehabilitation with following brachial plexus injury with a multidisciplinary approach. There are two other surgeons involved in the service now, Andy Hart and Kevin Little. We have a website which gives some further information about our service and information for referrals. Slide advancing is a bit slow there. So we see the full spectrum of brachial plexus injuries. And the number of referrals has increased over the years to around about 100 per year now, but the number of serious injuries that require operation has remained relatively constant and a smaller proportion of the total. Now, about 50% or more than 50% of patients we see have infraclavicular injuries. And so for us, the management of these is quite an important issue. Overall, among the patients we see, the majority don't need operation. About 20% in total have a nerve operation, and some undergo later secondary reconstructive procedures. So the aim of this talk is, as I say, concentrating on infraclavicular injuries, how to recognize those injuries, what the main scenarios are, and the principles of management of the nerve and skeletal injury for each scenario. So, as we know, brachial plexus injuries can be broadly divided into those that affect the nerves above the clavicle, the supraclavicular injuries, and those that affect the nerves below the clavicle. The supraclavicular injuries tend, as we know, to affect a combination of nerve roots, whereas the infraclavicular injuries affect the terminal branches of the plexus. So when we're examining patients, remember infraclavicular injuries are often, but not always, associated with a skeletal injury at the shoulder or in the humerus. We typically, the shoulder girdle muscles are preserved, the latissimus dorsi and pectoralis major. The suprascapular nerve may be affected, but is difficult to examine acutely because in the presence of shoulder trauma. And the pattern of loss tends to be to one or more of the terminal branches of the plexus, rather than being explained in terms of damage to a combination of nerve roots. So we just have a look at a couple of examples. This was a boy who was a pedestrian hit by a car, had a number of injuries, but partial paralysis of the left upper limb. And if we look at his muscle chart, we can see that there was complete loss of shoulder and elbow movement, including the shoulder girdle muscles, but there was some preservation of hand function. And this really can only be explained by a supraclavicular injury involving the C5 to 8 roots with T1 preserved. But in contrast, we have a look at this case, a lady who had a quad-right accident, partial paralysis of the left upper limb, bit of stiffness at the shoulder, but no identifiable skeletal injury. But she had isolated loss of deltoid function, weakness of triceps, and loss of ulnar nerve function. So this is an infraclavicular injury, which has primarily affected the axillary and ulnar nerves. So recognition of these patterns will point us to whether an injury is supra or infraclavicular. Historically, it was thought that management of infraclavicular injuries had quite a good prognosis, and conservative management was generally recommended. However, in the 1980s, some surgeons recognized that some infraclavicular injuries were more serious, particularly if associated with high energy trauma, and recommended surgical exploration. We looked some years back now at our infraclavicular injuries, and we found that they largely fitted in to 4 clinical scenarios when we took account of what the skeletal injury as well as the nerve injury. The most common pattern that we were seeing were injuries associated with anterior dislocation of the shoulder. Subsequent experience has sort of reinforced this analysis of infraclavicular injuries. So if we look first at the glenohumeral dislocation cases, we had 49, and this table shows the nerves that were affected. As you can see here, it was actually the axillary and the ulnar nerves that were most often involved. And in general, most of the nerves were in continuity and improved over time, although quite often the ulnar nerve recovers incompletely. Important note is that in this whole series, there were only 2 patients who had a nerve that was disrupted, and that was the axillary nerve in 2 cases, these being associated with higher energy trauma. So the remainder of the nerve lesions were lesions in continuity and were managed non-operatively. The important point in this group of patients is that 17 of them had either a large rotator cuff tear or a displaced greater tuberosity fracture. And it is important to diagnose that part of the injury early and repair or fix the rotator cuff, because failure to do it will lead to poor shoulder function in the longer term, regardless of the nerve recovery. Another scenario, the second pattern we noticed, was those who presented with an axillary nerve palsy, sometimes with other nerves affected, but without shoulder dislocation or recognized shoulder dislocation. In our series, there were 20 of these. They were tended to be higher energy injuries, younger patients, and some of them had arterial injury. 9 had scapular fractures, again, a marker of a higher energy trauma. The pattern of nerve involvement is similar to that seen in shoulder dislocation. The suprascapular nerve may be involved, but is usually a lesion in continuity that recovers spontaneously. But the important feature of this group is that 14 out of 20 had rupture of the axillary nerve. So if you recognize an axillary nerve palsy without shoulder dislocation, there seems to be a strong case for considering early exploration of the nerve. We usually repair the axillary nerve if ruptured with nerve grafts. It's important just to come back to recognizing this injury. In this group, the mean delay between injury and referral was quite long. And therefore, I think it's worth emphasizing the importance of recognizing this clinical scenario. The question then arises, how does the axillary nerve become is injured and ruptured without dislocation of the shoulder? Now, some patients have given a history that suggests that the shoulder may actually have dislocated but reduced spontaneously, which might be termed an occult dislocation. And there's one MR scan here where there is a Hill-Sachs lesion, which rather suggests that this shoulder has been dislocated at some time. As I said, we tend to explore the axillary nerve through a delta pectoral incision. As here, there's the part of the nerve, it's not easily seen, and we tend to repair it with nerve grafts. There's some nerve graft here which has been tunneled. You usually need to tunnel it through to an incision on the posterior deltoid to connect to the distal end of the nerve. An alternative approach is nerve transfer. If the triceps is working well, then transfer of the medial head triceps branch onto the axillary nerves becomes an option. The posterior in approach to the shoulder is extended distally, splitting the upper part of triceps. So that moving on to the third scenario, proximal humeral fractures. Sometimes there are injuries to the infraclavicular nerves in combination with displaced fractures of the proximal humerus. These are often low energy injuries, and the issue is medial displacement of the humeral shaft. Medial displacement of the humeral shaft, which directly impinges onto the neurovascular structures in the axilla. Any of the nerves may be affected, but quite often axillary and radial. In most of these cases, the nerves are in continuity, but they may be ongoing compression. If the fracture is still displaced or the nerves are still attached to the upper end of the humeral shaft, then there is ongoing compression, and there is commonly arterial injury as well. As mentioned here, often arterial injury. You can see here the shaft of the humerus directly impinging into the axillary artery, and again in this CT angiogram. So the management of these is a very urgent matter, either emergency or very urgent exploration of the plexus. I carry this out through an extended delta pectoral approach. The axillary artery is controlled, and then the nerve separated off the fracture, and the artery repaired if necessary, and then bone fixation performed. Example here, this was an 85-year-old lady who had a fall and a shoulder injury, presented with a high radial nerve palsy and absent pulses. You can see the axillary artery occluded on the CT angiogram. These are operative photographs. Now I've marked with the black arrow just to make it clearer. That is the upper end of the humeral shaft, which is impaling onto the axillary artery and occluding it. After disentangling the nerves, you can see the radial nerve here, which has been sort of notched by the pressure from the bone. And after arterial repair, a hemiarthroplasty was carried out. So for that, these, as I say, require a very urgent approach, with usually just decompression of the nerves, fracture fixation, and arterial repair if necessary. The fourth category is what I term an elbow or arm hyperextension injury. We had 11 of these cases. They were all due to some form of high energy trauma. Some of them had fracture of the shaft of the humerus, and some had an elbow injury, dislocation or fracture. But there were 4 who had no obvious skeletal injury. Arterial injury occurred in about half. The common factor was that the musculocutaneous nerve was ruptured. In 10 of the cases, in the 11th case, there was an anatomical anomaly which protected the main part of the musculocutaneous nerve. Other nerves may be affected, particularly the radial and median, but the ulnar nerve is least involved. And this pattern appears to be caused by a violent hyperextension of the arm, stretching all the nerves that lie in front of the elbow and the upper arm. Management, It involves urgent fracture fixation and, if necessary, arterial repair. The nerves are explored and usually repaired with nerve grafts. Repair of the musculocutaneous nerve is usually quite rewarding. The example here, ruptured musculocutaneous nerve, we can see through a delta pectoral incision here. Nerve grafts obtained from the lateral cutaneous nerve of the forearm distally have been tunneled from a medial arm incision and then attached here proximal to the neuroma and distally onto the two main motor branches of the musculocutaneous nerve. So just to recap on a few general points, we've got, say, 4 scenarios which, if we recognize, point to a system of management. Firstly, arterial injury. We usually define arterial injury with nowadays with CT angiography, which can be done quickly. Emergency operation is debridement, skeletal stabilization, arterial repair, soft nerve grafts for the ruptured nerves, and soft tissue cover. And if that can be achieved very early as one procedure, that may be appropriate. A more delayed approach to the nerves in some cases. I'd also like to just clarify the assessment of the shoulder when there is loss of active shoulder abduction. It's worth remembering that axillary nerve palsy alone doesn't cause complete loss of shoulder abduction. This gentleman has an axillary nerve palsy, but has full shoulder abduction as a result of the rotator cuff muscles. So if there is complete loss of shoulder abduction, then there has to be either a suprascapular nerve injury or a rotator cuff tear. And this situation can be defined quite a lot, fairly easily with MR scan of the shoulder, which will show you rotator cuff tears, and early repair of those can be arranged. So in summary, 4 patterns of injury: shoulder dislocation, nerve injuries associated with shoulder dislocation can be usually managed non-operatively. It's worth confirming that the axillary nerve is recovering after 2 to 3 months, particularly after high energy trauma. Axillary nerve palsy without shoulder dislocation, there's a high risk of axillary nerve rupture, and early exploration should be considered. Humerus neck fractures operate very immediately to decompress the nerve and fix the fractures. And arm hyperextension explore and repair the musculocutaneous nerves and other nerves. And another general point is always, which is common to many nerve injuries, is to introduce physiotherapy, particularly hand therapy, very early in management to maintain passive joint mobility while nerves recover. And we've found hand stiffness to be a significant limiting factor following these injuries, where the nerves generally recover spontaneously. Thank you very much for your attention. These are a few other sources of information, and I'd be happy now to try and answer some of your questions.
Thank you so much, Dr. Tim, for this incredible and outstanding presentation, especially on a topic which is very emergent to intervene, especially if it's infraclavicular injuries with an arterial injury. I think these are the vital, important informations which every viewer should understand. I think you're balanced, talking about all 4 types of injuries you've seen across in your practice, and then different treatment modalities for managing the axillary nerve injuries, with the grafts and nerve transfers. Similarly, managing the medially displaced fracture humerus. I think that's one area of concern for fracture fixation where you need to properly segregate the medially displaced fracture humerus from the most neurological structures there. And in addition to that, you also pertinently told about the dislocations and pattern of axillary nerve injury there. Additionally, you also touched upon the musculocutaneous nerve. It's also commonly injured in all those infraclavicular injuries and the management. I think it's really um, a wonderful talk, and what a great year to start with Dr. Tim on this topic. Now, I invite Brigadier Dr. Bhandari sir to comment on this and also to have his views and his treatment modalities on this infraclavicular brachial plexus injury. Sir, please go ahead. You're muted, sir.
Yeah, thanks, Dr. Timms, for your lucid presentation on infraclavicular brachial plexus injuries. In fact, I was going through your article which you published in Journal of Bone and Joint Surgery in 2012, and most of your injuries were related to the axillary nerve and the ulnar nerve, and many of these injuries were associated with the fracture dislocation of the shoulder, and most of the injuries you could treat conservatively, isn't it?
Yes,
Only few of them require nerve surgery.
yes. For the patients who have dislocation of the shoulder, as you say,
Yeah,
sometimes
yeah,
associated with the greater tuberosity fracture.
yeah. But what I see in my practice is that these injuries are technically more challenging than other kinds of brachial plexus injuries. The reasons are, first of they are many times associated with vascular injuries, which are often missed, you know, and these patients usually come late. The reason is, in majority of the cases, the supraclavicular plexus is intact. The suprascapular nerve is functioning. So, whenever the patient goes to the clinician, generally the advice given is that because some function is normal, it is possible that you might get return of functions distally also. I think that is a wrong advice. So these patients are generally not, uh, they are not treated early, and they'll end up in various kind of physiotherapy and electric stimulation and other modes of treatment. The other aspect is investigation part. When MRI is done for these kind of plexus, and when the emphasis is more on the supraclavicular plexus, the MRI generally gives more or less normal report because the roots, they look normal, and that is another thing which delays their arrival to a proper referral center. Now, when I share my experience with you, what I find is these injuries are most commonly involving the lateral and the posterior cords. In fact, they are quite matted together, and then comes the medial cord. And involvement of lateral cord, it extends distally, and especially with the fracture humeral neck or the shaft, there is an associated injury to the musculocutaneous nerve also. So, when we explore these lesions, which usually present late, they are not generally coming to us within 3 months or 4 months, because the patient have got lot of expectation that some function is intact, other function will also improve with time. They usually come after 6-7 months of injury, and that time when we explore them in the infraclavicular region, we find lot of fibrosis is there. Thick fibrous tissue is engulfing the nerve tissue, that is the lateral, posterior cord, medial cord. It's and just underneath you will find the vascular structures are also they are within the fibrous tissue. So when we try to tease off, when you try to do a kind of separation of these nerves, lateral, posterior or the medial cord, the injury to the vessels are very common, because by the time the veins have also formed some abnormal communications. So we have to be very careful while we dissect this kind of lesions, and inadvertent injury to the veins, the axillary veins or its tributaries, it's not very less common. In fact, artery is also sometimes is in very close proximity to the cord, and we have to be very careful in separating the artery uh, from these lesions. So what I wanted to convey here is that it is these lesions should preferably be operated early. They should be diagnosed early when the fibrous tissue has not formed much, and dissection will be easier, so that we can do a neat dissection without injuring the vascular structure. So this is my experience in this, and most of the lesions are related to the lateral posterior cords in my practice. Maybe because that part is more in close proximity to the humerus, where the fracture is there. And another thing which I would like to highlight is that when we tackle these injuries, uh, we must uh, be prepared to repair the vascular part also. We must be ready to, if some vascular injury happens, we must be ready with the vascular clamps, with the sutures to repair the torn vein, which is more frequent than the artery. So this thing we always we must be prepared for. And also my request to the surgeon who primarily tackles the reduction of the fracture humerus by plating or any other modality, there should be minimum force should be should be exacted onto the onto the arm, because what I presume is there is an initial trauma which has caused the injury to the plexus in that region, and if we are little rough in fixation and uh, in mobilizing or in doing the close reduction of the bone, we might produce additional trauma and additional fibrosis in that region. So this is another thing which I'd like to highlight. And I think you have covered nicely all other aspects, and uh, the if we discuss about the results of the posterior cord and lateral cord and other aspects of infraclavicular plexus, what we find that the results of repair of lateral cord and musculocutaneous nerve are always better than the medial cord repair, which usually yields in very poor results. One of them is because of the late presentations, the other is because of the quality of nerves and their distal innervations. So these are the certain things which I wanted to highlight, And in my practice, what I find is that tackling the infraclavicular plexus injuries when there is lot of fibrosis and when the vessels are also sharing the same walls with the neural structures, one has to be very, very careful in handling these lesions.
Definitely. I think we are perhaps fortunate that a lot of injury patients are referred to us very quickly,
Yeah,
and certainly almost all the nerve injuries directly related to humeral shaft fractures will get operated within a few days. As a primary event, and particularly if there's been an arterial injury, then that if that's recognised, it will push the intervention to being an emergency event. I would again highlight the patients who haven't had a shoulder dislocation but have an axillary nerve palsy, sometimes with some other injuries. These have, I have to say, we tend to see them reasonably early, but often it is a month or two after the injury. And at that stage, our management will tend to be towards carrying out neurophysiology tests to see if there's any evidence of early recovery, but if not, then proceeding fairly quickly to exploration of the nerves. And for the shoulder, the low energy shoulder dislocation cases, as I said, most of them don't need or benefit from nerve surgery, but they nevertheless have a significant morbidity and disability from the injury, which may only partially recover, particularly the hand.
yeah, thank you. I'll give you a situation, if the patient comes early with infraclavicular brachial plexus injury and vascular injury, axillary arterial vessel injury, what should we do? Immediate repair? When you find that the distal part of the limb is otherwise surviving?
Well, that's a good question because the limb will often survive, but we tend to involve our vascular team and let them make a decision on whether repairing the vessel is necessary. But I have to say, in recent time, we have tended to, on the whole, repair the vessel in most cases.
Okay. Now the another situation is if the patient comes after 6 months, 7 months like that for the repair of the nerve injury and he doesn't have any vascular compromise, but when you do the angio and all, the vascular injury is detected. So, limb is surviving well, and what should we do? We should restrict ourselves to the nerve repairs, or simultaneously we should go for vascular reconstruction also. I'm talking about the late presentations.
Yes, I have to say I don't have much experience of that, but I think it's fair to say if the limb has survived for some time, then it's probably reasonable not to repair the artery unless ischemia becomes evident during the procedure or after it.
I agree with you. I faced such a case, similar kind of case about 3 days back. Patient had come to me about 8 months after the injury with vascular injury, and his lateral posterior and middle cords all were matted together. So I restricted myself to the repair of the nerves, not going for any vascular reconstruction.
I think one thing that experience I have noted needs to be aware of, perhaps is an earlier stage even, is that the limb may survive acutely, but at operation, anastomotic vessels may get ligated.
Yeah.
Um,
I think
and that,
these collateral vessels.
yeah, so there is some risk of operation compromising the
Yeah.
anastomotic circulation, which might then
So,
necessitate an arterial repair. But I think I've only really encountered that in a situation within a week or two of the injury.
yeah, in such cases, my suggestion is that we should restrict the size of incision, number one. Number two, we should try to preserve these collaterals as much as possible. We should not unnecessarily ligate and coagulate them. Whatever collaterals we encounter during exploration of these structures. So that is what I do, because knowing very well that limb is ultimately it is surviving only on the collaterals.
So it's
So that
important to
precaution one
preserve
has
them
to
if
take.
possible.
Yeah, one should not go immediately, coagulating all the small thin vessels. They may be the ultimate cause of survival of the limb. And length of incision should also be reduced so that the skin gets sufficient blood supply from the surrounding area. So that precautions I do take in such cases.
Certainly makes sense.
Sure.
Yeah, Dr. Terrence.
Sorry to interrupt you. We have two quick questions from the audience. We'll
Yeah.
pick on the questions. I think both of the panelists here can express the opinion on those issues. One, Dr. Bharat Reddy from India is also a very close friend of mine. He's also an interesting brachial plexus surgeon there in Bangalore. He had asked whether do you really co-opt or transfer the middle layer of triceps branch to the anterior axillary nerve or the anterior axillary nerve? One.
The medial head triceps nerve, we transfer onto the anterior branch of the axillary nerve usually.
Perfect. And the other question which I had also received in one of the Facebook Messenger is that you have shown the two aspects of treating axillary nerve. One, putting nerve graft. Other is the nerve transfer, distal nerve transfer. Again, the most common question: which one you really prefer, a nerve graft versus distal nerve transfer, and when do you prefer these surgery?
Right, there's not a clear-cut answer to this, but our usual approach is if we're operating fairly early, within sort of 4 months of the injury, would be a nerve graft. But there are one or two issues that sometimes arise. The axillary nerve may be ruptured very close to its branch from the posterior cord, and it can then be difficult to safely separate the nerve above the lesion away from the rest of the posterior cord, and that may therefore make nerve graft less attractive, and a nerve transfer better. The other thing, though, is that for a nerve transfer, the triceps has to be working normally. One pattern of injury I may not have highlighted, but there was an example in my talk, is that the triceps branches of the radial nerve are sometimes injured with axillary nerve injuries, and that is not that uncommon a pattern of injury. So if the triceps isn't working, you haven't got the option of a nerve transfer. You've really got to do a graft.
Thank you so much. Dr. Bhandari, would you like to comment on this question?
Your first question was medial head transfer to the anterior branch of axilla. My choice is long head. I do not do medial head. There are many reasons for that. One of the main reason is it is the first branch which comes from the radial nerve, and the other advantage is we can get a good length of the long head triceps branch. We can dissect internally, we can go more proximal on the radial nerve, and in conditions where there is injury to the axillary nerve in the quadrangular space, in some cases where these are cases where the injury is in the greater tuberosity of humerus or upper end of humerus, surgical neck of humerus. In such cases, we encounter that the area in the quadrangular space is not very virgin. We encounter fibrous tissue. The axillary nerve are not looking absolutely normal. They are surrounded with the fibrous tissue. Now, when we try to explore them, we don't get much length of the axillary nerve proximally, and it is possible that the axillary nerve might be injured when it enters into the quadrangular space. So, getting a good length of axillary nerve or anterior branch of axillary nerve, it becomes a problem. So, what we do in such conditions, that we should have a good length of long head triceps branch. This length can only be achieved with the long head, not with the medial head. We can mobilize a good length, and this is the first branch which is in close proximity to the axillary nerve in the quadrangular space. And if we do a partial division of the teres major, that makes more convenient for the long head triceps branch to reach to the anterior branch of axillary nerve. Even I have done this long head triceps branch cooptation to the just a small stump of axillary nerve very close to the deltoid. So, this much of mobilization is possible with long head triceps branch, which is not with the medial head. The second is that the long head triceps branch has got more number of motor axons as compared to the medial head. So, I don't think this should be a dispute, whether we should take a long head triceps branch or medial head triceps branch. Recently, I presented my paper on as a modified Somsek procedure, in which the title of the procedure, the title of the article or the lecture was the teres major approach in long head triceps branch to uh, axillary nerve transfer. So, in this I have described, I have given all the reasons why we should be going for the long head triceps branch and not for the medial head triceps branch for the axillary nerve. The main reason for them is if there is an injury to the axillary nerve in the quadrangular space, which is not uncommon with the upper hand humeral fractures or the fractures of the glenoid cavity of the humerus. In such cases, we don't get enough length of axillary nerve. So, we have to have a very good length of long head triceps branch, that is possible only with that. So, this is the first question, and what was your second question?
The choice or the preference in situations where you put a nerve graft between the axillary nerve, and when do you do a distal nerve transfers? Given a scenario,
Yeah.
when do you prefer a nerve graft? When do you prefer
Yeah.
a distal nerve
Now,
transfer?
the I think Dr. Tim has already answered this question. He says that if the patients come early, and then we should go for grafting, and if they are coming late, then we should go for nerve transfer. Here, I would like to mention that if we are very sure uh, about uh, the viability of the proximal nerve segment, it has got good number of fascicles and viable, then we must put it grafts to the distal segment, and especially when the defects are not big. It will depend upon when the patient presents. Like putting 10-15 centimeter grafts to bridge the medial cord when the patient is presenting about 8-9 months after the injury, I think that will be futile. So in such cases, we must consider if we can do the nerve transfer procedures, that will give better results. And I think in such cases we can do the long head triceps branch to axillary nerve anti-branch, or for median for the musculocutaneous nerve injury also I'd like to mention, if the gap between if you want to do the grafting, the nerve defect between the lateral cord and the musculocutaneous nerve, we encounter certain cases where the musculocutaneous nerve, it is not the injury which is only at the lateral cord. The musculocutaneous nerve is also injured quite distally because of the traction forces at the time of the first trauma. Number two, the traction forces which are exerted at the time of the fixation of the humeral bone. So here we expect very long gap to put the grafts. So to circumvent this situation, what we can do is, if the median nerve function or ulnar nerve function is normal, I'm talking about here isolated lateral cord injuries. So we can do the fascicular nerve transfer from ulnar median to the biceps brachialis. That will give better results than putting 10 centimeter grafts to bridge the segment between the lateral cord and the medial cord, musculocutaneous nerve. So,
Yeah, the message is very clear and loud. We are like 1 minute shooting apart from the time, so we can take one question, the last question from the delegate. Dr. Sheenam Bansal has asked a question, probably not relevant to the topic here. The question is the use of vascularized ulnar nerve graft. I think this is somewhere related to the supraclavicular brachial plexus injury. I don't think this suits. Can both the panelists have quick thoughts, few seconds of this use of vascularized ulnar nerve graft? Does it have a role nowadays?
It would very occasionally. We haven't done very many, but there have been some complete injuries of the plexus where there was no possibility of the ulnar nerve recovering, where we've been able to use it to reconstruct from the upper roots of the plexus. And it equally could have a role in extensive infraclavicular injuries if the ulnar nerve seemed less likely to recover, is being ruptured and less likely to recover, then some use of the nerve to repair the median or the radial, which have got a better chance, may be a reasonable thing to do. But it's not a common scenario.
This was reported by Dr. Chuang and his teammates, and it was published in PRS in 2014, in which he has described this vascularized ulnar loop. But I don't think anybody is using this kind of method in tackling the nerve grafting procedure. And I am yet to see, I'm not doing in practice. I would rather prefer the conventional nerve grafts than going for the procedure which I'm not sure about.
Thank you so much, panelists. I think we are trying to accommodate this IPL Series 2020. So we had a quite good number of discussions on the topic. We are getting more questions. Probably we can direct the questions to email to the panelists. And thank you so much for attending this meeting. The Interact with the Pioneer and Learn series we call as IPL Series, a fascinating name for the cricket 2020. Which include 20 minutes of a talk by the pioneer and discussion of 20 minutes. So before concluding and before ending this session, quick 10 seconds, 20 seconds comments from both the panelists, and then probably we can wind the program.
Well, thank you very much for inviting me and listening to the talk and the discussion and input from Dr. Bhandari has been very interesting as well.
Yep. Thank you so much,
Yeah.
Dr. Bhandari. Yep.
Yeah, certain points here I would like to highlight for the infraclavicular injuries is that they differ from the conventional BPI injuries which you are managing. Whenever these patients present to the clinician, they must understand that it is not the only supraclavicular plexus is always injured. There might be injury to the infraclavicular plexus, which is a separate entity. So just by saying that the patient does some abduction and all, they should not be in the impression that he is in the process of recovery. Okay, that kind of knowledge should not be given to the patient. These patients get delayed. As I said, if you operate them late, we encounter such a very hard, thick fibrous tissue. It doesn't cut with the knife also. It becomes so. Secondly, there is formation of abnormal vessels. Abnormal vessels. Mainly the venous formation is there. A small tributary is developed around that area, and it becomes very meshy to dissect that area. And we must also know that the results of the repair of the lateral and the posterior cords are good, but in spite of all our best efforts, in these injuries, the medial cord, especially the medial ulnar outflow, doesn't give good results. So that becomes a problem with the infraclavicular injuries, though all injuries are not of same magnitude.
I think the important message you're putting there is refer the patients early
Yeah,
to a specialist.
and always keep the vascular injury in mind. Whenever a patient comes who is showing abduction, but there is no elbow flexion and finger movements is either minimal or it is not there, always feel the radial pulse. Always palpate the radial pulse, because around 15 to 20% of infraclavicular injuries, they are associated with the vascular injury. So that needs to be documented prior to surgery. Otherwise, uh, it will be attributed to the surgeon's exploration and repair. So prior to the surgery, the patient should well informed about the vascular injury. If required, one should always do the CT angio or any other methods to convince the patient that you have got vascular injury and your limb is surviving on the collaterals, and so that the patient is well informed prior to surgery. Otherwise, he will be contribute the vascular compromise if he comes to know to your exploration.
Thank you so much. Anything you want to comment, Dr. Tim?
No, I don't think so further. I think early referral to a specialist is important.
Perfect. So, ladies and gentlemen, I think sorry that we have to leave on time. Today, we have learned a lot of things, especially on this topic. I am echoing the thoughts of both panelists. Early intervention is the most mandatory thing, especially if we're dealing with the clavicular injuries. Beware of vascular injuries, as Dr. Bhandari said, and more or less the attention to the fracture fixation and also the different type of nerve injuries, nerve repair treatment gives at least a good result. So that's it for today. Happy New Year. Thank you so much for all joining us. We will meet sometime in the next month for the same series. Thank you. Bye-bye. God bless you.
Thank you, Dr. Terrence. Thank you, Dr. Tim. It was nice, nice talking to you after 13 years.
Yes,
Thank you so
and
much.
you.
Yeah.
Good to see you looking well.
Yeah. So very soon we will be seeing each other in one of the meetings.
Yes, I hope so.
Yeah. So all the best. Okay.
And to you.
Okay. Thank
Thank
you.
you very
Bye-bye.
much, Terrence.
Thank you so much.
Bye-bye.
Yeah. Bye.
Bye now.
Bye.
Bye-bye.
Thanks.